Great. So I can see some people are filtering in, so welcome. Thanks for joining. We will give it a few minutes, but I also have a lot of questions to ask our expert panel about women's heart health today, so I'm going to keep things moving. For those of you who don't know, my name is Dr Niamh Chapman, and I'm a Menzies postdoctoral researcher, so that means I've just finished my PhD and I'm working in cardiovascular disease prevention, and I'm really passionate about how we improve health service delivery to prevent avoidable deaths, pretty much, is my passion in a nutshell. So I'd like to begin today's session with an acknowledgement of country and acknowledging the traditional owners of the land in which we're all gathering today. So for me, that's Lutruwita in Tasmania, but I would like to respect the First Nations people wherever you are joining us from as well. On behalf of everyone, I pay my respects to elders past and present, as well as the Aboriginal and Torres Strait Islander community who continue to care for country. And I recognise a history of truth that acknowledges the impacts of invasion and colonisation on Aboriginal and Torres Strait Islander people that resulted in the forcible removal from their country, as well as an attempt to remove connection to those ancestral land, sea, waterways and skies. I stand for a future that profoundly respects and acknowledges First Nations perspectives, culture, language and history, and the continued effort to fight for justice and rights, paving the way for a stronger future with our Indigenous communities. So it's my great pleasure to move along swiftly to introducing our panel, because I've got, as I said, many questions. And I'd like to start by introducing Professor Alta Schutte. So Alta is a professor and principal lead of the Cardiac, Vascular and Metabolic Medicine theme at the University of New South Wales in Sydney, Australia, and the George Institute for Global Health. She is also extraordinary professor at the Northwest University, South Africa. With over 350 publications in the field of hypertension, it is fair to say that Alta is an expert in the area of high blood pressure and cardiovascular disease, and is involved in numerous international consortia, including the Global Burden of Disease Study, which I'm sure many of you have heard of, and is also an invited author of the Lancet Commission of Hypertension, which is a group of experts paving the way for how we come together internationally to improve high blood pressure management. She is past president of the South African Hypertension Society and immediate past president of the International Society of Hypertension. Thank you for saying yes, Alta, to being on this panel.
Thanks, Niamh. Nice to be here. Thank you.
Next, I'd like to introduce Professor Gemma Figtree, who is a professor in medicine at the University of Sydney. She co-leads the cardiovascular theme for Sydney Health Partners at NHMRC Advanced Health Research Translation Centre and is the chair of the University of Sydney's Multidisciplinary Cardiovascular Initiative. Gemma is committed to improving the care for heart attack patients using her knowledge of molecular and cellular biology to develop methods of identifying those at highest risk of adverse outcomes and discovering new ways to prevent and treat events inspired by her clinical work as an interventional cardiologist. And she is the current president of the Australian Cardiovascular Alliance. Welcome, Gemma. And then last, but definitely not least, is Professor Julie Redfern, who is a professor of public health, a practicing physiotherapist, a research academic director at the School of Health Sciences, University of Sydney, and a professorial fellow at the George Institute for Global Health. Julie has more than 15 years of experience developing, testing, and implementing new strategies that can be implemented on a big scale to close evidence practice gaps and improve health outcomes for people with chronic disease. She has expertise in multidisciplinary and translational research that can have a real-world impact and is an advocate for effective secondary prevention of cardiovascular disease. Julie's research interests is focused on improving clinical practice and reduction of risk factors, ultimately in people with a range of chronic diseases. And Julie is co-chair of the Clinical and Preventative Cardiology Council of the Cardiac Society of Australia and New Zealand, and co-chair of the National Secondary Prevention Alliance and part of a team that won the 2016 Australia Google Impact Challenge. So with those introductions, I think you got a sense of the type of panel we're working with. It's people who are experts, which is very exciting, but also really focused on a big problem because it's the #1 cause of death and disability in the world, cardiovascular disease. But they also are really focused on what we can do about that in a tangible and practical way, ranging from lab-based development of new solutions and understanding physiological mechanisms of how our body works, right through to, okay, now how do we take that solution and put it into the real world? So that's why I'm really excited for this panel. And the way that this discussion is going to work is I've got a bunch of questions planned, but I'd love to hear from you. And we're going to go through in sections from like, what are the risk factors of heart disease and stroke? How do we assess whether or not somebody's at high risk? Then if we know somebody's at high risk, what do we do to treat and manage that? What are the differences between outcomes? And then what do we do after someone's had an event? So because we're going to do that in sections, feel free to pop your questions in the Q&A at any time, because I am mindful we only have an hour. So I'm really keen to hear from all of our attendees today. So to get us started, Alta, could you give us an overview of the major risk factors for developing chronic disease like heart disease and stroke?
Yeah, thank you very much, Niamh. I think some of these risk factors are the stuff that we all hear and read and have read for 20, 30 years. The problem is people are not really paying the attention that they should. So, but let me just highlight some of the major ones, which is, of course, tobacco use, smoking, alcohol use, and what we eat. So eating more fruits and vegetables and eating less salt, and also the issue that we don't eat enough fiber is becoming more and more of an issue. And then I think cholesterol is, of course, something that's always very important in cardiovascular disease. But one of the main risk factors that's often overseen, also here in Australia, is raised blood pressure. So globally, raised blood pressure is the leading cause of death, including cardiovascular disease through coronary artery disease and stroke. And globally, it leads to about 10.8 million deaths every year. And what's quite disturbing for me is in Australia is the study by the Heart Foundation found that only 4% of Australian adults actually recognize raised blood pressure as a major risk factor for cardiovascular disease. So that's why I am here today, I think, to encourage you all to really focus on also your blood pressure, which is a relatively easy measurement to do. And in fact, this month is also my measurement month, which is the global initiative to raise awareness for hypertension. And also in Australia is to have your heart health check, which is now a great initiative and tool that we can use to actually go to GPs and get your heart health check as a basic number of measurements to be done, and it's covered by Medicare. So maybe I'll stop there.
I think that's a really nice overview, and it's a good call to action. It's also May Measurement Month, so a good time to know your blood pressure numbers. So do you think that typically at the minute, our attendees may be aware that a blood pressure that's over 140 over 90 is considered high, but then also if you're going to have a heart health check, that looks at all of your traditional risk factors. So like if you smoke or have diabetes, and then if that score that's produced is over a certain threshold, then you're high risk. Do you know if these risk factors, either the presence of them or the way that they increase your risk, differs between men and women? And Gemma or Julie, feel free to jump in at any time.
I think overall it is, in general, it's similarly applied to men and women. There are nuances where that changes. For example, women, in terms of blood pressure specifically, usually have lower blood pressure than men, but as menopause kicks in, this really changes quite substantially. And then that increase in blood pressure after menopause really increase risk for cardiovascular events. So to my understanding, it's generally similarly applied, but there may be some nuances.
Yeah, I think,
Gemma, I know that you have something to add to this. You've recently published on traditional risk factors in men and women recently.
Yeah, I think it's really important to know that at a community level, the key risk factors, which we're still not very good at addressing, need to continue to be upfront. But there's a huge amount of individual susceptibility to these things, including to hypertension. I mean, there are many very fit people that suffer from hypertension, and certainly being able to measure that means that we can then apply appropriate preventative management. So I would certainly concur that hypertension is one of the most important modifiable risk factors, and we shouldn't put our head in the sand and just ignore high readings if you get them. Just make sure that we, see this as something that is a really important issue to address. But in terms of what targets, we do know that, that there is not really a binary kind of approach to blood pressure. And in a way that in a clinical setting we deal with this is we try to obviously optimize every individual's vascular health. And that's driven our kind of the efforts that we go to reduce blood pressure partly depend on the developed cardiovascular disease that the individual might already have. So if they've already got coronary artery disease or already suffered a stroke, obviously that puts them at very high risk. But secondly, it's actually that combination factor. So if you do have a history of smoking or you've got diabetes, we're much more aggressive with our goals for your blood pressure. But having said that, each individual, if they want to optimize their health, you can't go too low with your blood pressure. Really it's very difficult. We should actually be running around with blood pressures of 100 on, get your systolic down to 100 and you'd be, it's a very good prognostic sign for you in general. So we're here to optimize each individual's health, but we also have to think about the big public health message. That's probably enough from me for the moment.
Yeah, I think that's really interesting of how we trade off, I grapple with this as a scientist, of how we translate something that's like a population health finding or like something that's generalizable from a research setting into individual person-centered care delivery, where people may not want to take medications or intervene for that aggressively. But I suppose I like that you're saying there's a gradient as well. You don't have to wait till you hit the threshold. If we know your family history or if we know your history of traditional risk factors, it may be appropriate to intervene early. So the next thing I'd like to talk about would be, how do we actually go about assessing someone's other risks? So Alta mentioned the heart health checks, which I really like, and they're my main research focus actually, is embedding that into care. But what other ways do we approach it? Do you think that opportunistic checking in with your GP is appropriate? And then how do you keep an eye on that? So I wonder if Julie or Gemma, do you have anything to add from like a clinical perspective of when and how do we start assessing risk factors?
Yeah, I'm happy to jump in and then pass over to Julie. But I mean, I think given we're focusing on women here in particular, I think it's partly raising awareness around the fact that women die of heart disease, as much, if not more than men over our lifetime. It does tend to, as Alta said, occur at a little bit of a later time period. But young women still suffer heart attacks, and that's my job, treating them. And last week we had 2 young women, under the age of 50, so who'd suffered life-threatening heart attacks. So this is something that we shouldn't ignore, and we as clinicians need to be looking for opportunities not just for public awareness, but on an individual level, taking life opportunities to talk to people about their risk. And pregnancy is a really interesting one for women. Partly as just a reminder that their health is going to be so important, not just for them, but for their family, and that's a major motivator. And I think obviously it's a good time to get people to stop smoking if they're smoking, but also some of the response to pregnancy is actually a really good marker of cardiovascular susceptibility. And so hypertension or diabetes during pregnancy is a really important alarm bell. But also some less typical factors, such as actually small for gestational age babies or even premature babies, actually can be a marker of some degree of heightened risk of susceptibility to cardiovascular disease in the future. And that's probably due to the important adaptations that happen during pregnancy that are so critically dependent on our amazing cardiovascular physiology. And if you actually don't adapt that well, you end up with some of these challenges. And so pregnancy is a great time for us to actually remind women that their hearts are so important and that they are at risk over time and they can optimize their health. But also just to say that women in general have a less predictable, you can't use traditional risk factors in women as well as you can in men to predict their risk. And that's partly because the models were actually developed on men. But also, there's different biology going on here that we still need to kind of work with. So anyway, that's probably enough from me, and I'm happy to hand over to Julie about how we can continue to do better.
Could I clarify if that low birth, I've never heard that before. So if as a woman, if you have a preterm baby or a low birth weight baby, you then as the woman are at higher risk, not the infant? Because I knew the infant was. Wow, I didn't know that. That's really interesting.
And obviously the biology is complex, but it is particularly the small for gestational age thing's really interesting in terms of, the way the uterus and effectively the baby adapts is dependent on the mother's cardiovascular adaptation. And that's actually quite a stress on the body. I mean, it's almost a 50% increase in blood volume during this period in the female. And so if you can't quite adapt to that, and you can't, you know, I guess the blood supply and the way the blood vessels in the placenta work are all kind of reflective of cardiovascular health in some way. And some of that may be genetic and some may be environmental or other exposure. But it's really interesting that pregnancy is a great time, not just to make the awareness, but also to pick up, you know, some atypical risks.
Yeah, so we do have a question that I'm going to flag in case it would come into Julie's response. But the question from, I think, a Facebook attendee is, how well do the current risk prediction tools compare in men and women? And also, is there a role for different ancestries, or I would just add to that the family history? So Julie, do you have anything to add to what Gemma said? Then we can have a bit of a discussion about how things have been developed.
Okay. So, I mean, what I think, firstly, just pick up on Gemma's point that the traditional risk factors were kind of modeled and developed mostly on a big data set of people that were mostly men. And in fact, most of the research until more recent times of the treatments and the strategies, whether they be medicines or, you know, digital strategies or other person-to-person strategies, also the majority of research was driven with the patients participating being men. And so that's clearly something that we need to work on. So to pick that up from what Gemma said. So traditional risk factors, I'll let the others say something after this. I'm not exactly sure of any current research that compares, you know, the difference between the two, except to say that the traditional risk factors aren't the full answer to the question necessarily in women, as Gemma alluded to. I think another couple of things to say are that women in a general sense often put others before themselves. That is a generalization, but this is part of one of the issues that comes up. Women often typically, you know, aren't proactive in managing their own health sometimes. They're busy, potentially, you know, running other people around, family members around, and perhaps put their own health second. And so that is considered to be a bit of a factor, particularly for women, and women need to be mindful of their own health as well. And typically and traditionally, heart disease has been considered a man's disease or a men's disease in some way, and that's part of this conversation and all of the hard work of many people, including the Heart Foundation. And I suppose just to add to that, with this along that same flavour, we do know issues such as depression and anxiety and some of the social things I alluded to and Gemma touched on have a stronger association with heart disease in women than men as well. And I think all of those areas really need a lot more work and a lot more research. But I don't know if Gemma and Alta have any other direct knowledge of research that has directly looked at those traditional risk factors in men.
Yeah, Alta, I was wondering if I could go to you with both the sex differences, because I've seen some really nice work with blood pressure across the life course recently, but then also you've done a lot of international work. So the role of ethnicity or socioeconomic status in those risk factors and how that might be different.
Yeah, I will definitely respond to that, but I also want to mention this in terms of behavior. I think we need to acknowledge the fact that many women often have better health-seeking behavior. So they would sometimes easily go for cancer screening and so on. Women, I think, are much better than that than men. And also in terms of, I know there's been studies in the US that show that more women with hypertension actually take their blood pressure treatment, but less are under control, because the clinicians often have inertia. They hesitate to add additional medication for women, because traditionally, as Julie just said, traditionally women hasn't been seen as the population that really suffers mostly from cardiovascular disease. So I think there's, from the clinical side, also some sort of a behavior change that's required to make sure that women are getting the treatment that they need to address, whether it's blood pressure, whether it's lipids, etc. Then just to follow on, Niamh, from your reference to socioeconomic status, so we know that health inequalities is a major issue. Also, even access to healthcare in remote areas and in people with lower incomes, that is a major challenge. And I think we need to find ways to encourage people to seek even just basic training. there's definitely a higher risk in those populations, even in remote areas in Australia when compared to urban areas.
Absolutely. And the disparity between outcomes in women versus men is much worse in the rural and poorer communities, for sure. I mean, Niamh, I guess one of the interesting things about your question is actually, and I think it actually ties into people's behaviour in a setting, is that there is a difference in susceptibility to traditional risk factors, and particularly resilience in some individuals to risk factors. And so, I mean, there are great examples of people that have smoked all their lives and have no coronary artery disease. And that's kind of, you know, one example. But equally, people who may actually have genetically acquired really high cholesterol, but yet somehow they're immune to coronary disease. And I think this group are really interesting, partly because I think as a biologist, if we can unravel those mechanisms of resilience to the risk factors that we know should be damaging their blood vessels, that could give us really breakthrough advances in the way we actually, you know, think of treating cardiovascular disease. We can develop new therapies for people that might be really effective. But furthermore, I think that it actually, people know these people, they're out there in the community, and I think it actually influences behaviour. Because if you know people that have smoked all their lives that have got away with it, inverted commas, that's actually absolutely driving other people's behaviour. And, you know, people might not be wanting to take their blood pressure medications because they know somebody that didn't and they do fine. So this understanding an individual's susceptibility to risk factors is something that we need to do better over time, partly because it will help the people who are at moderate risk actually know that this is going to be so valuable to them and actually them as an individual. And I think we still have to think public health, but I think if we can actually get better at understanding those mechanisms, I think it will help people adhere to the recommendations that we are making and make it feel personal.
One thing that always perplexes me is how everyone can kind of think of maybe some distant relative that knows someone that lived to 90 when they were smoking. But I mean, that's pretty, we know that that's relatively exceptional, but why that's something that we're like, oh, but you know, they got away with it. But 1 in 3 people have high blood pressure or will have a cardiovascular event. Like, it's people we know. And I'm wondering, like, when did it become a thing where having a first event is just fine, or that we're not alarmed by it, and why we're not alarmed by the thing that is the most prominent cause of death? And I don't know how that complacency or that inertia has crept in. And I'm conscious of time, I'm wondering if we need to think a little bit about treatment and management, because it factors into that behavior approach again. I had one question about whether or not, so Alta mentioned that, you know, women in the US are take more blood pressure medications, but compared to men, but they have poorer blood pressure control. And I wonder if that's a factor as well, of just the fact that maybe the treatments weren't developed with women in mind, so they're not as effective, and how we actually measure, is this inertia and maybe some inherent thinking it's not a women's disease, or is this that actually the treatments we have aren't as effective in women? Is there any evidence of that?
Now, in terms of blood pressure medication, there's been quite a lot of thorough investigations. Here and there would be a smaller study that would indicate that this specific agent is not working as well in women as in men, or other way around. But when you look at the major meta-analyses comparing men and women, there's no difference, I think, in terms of the impact of the medication. So I think we can move away from that as the major contributor. I think it's rather whether it's a single monotherapy or single agent that's being given to women, where it should be 2 different combinations. So I think it's rather in terms of how well they are treated.
So you think it's more that behavioral level of either the individual taking the medication or the doctor prescribing and being like as proactive in managing that medication schedule? Yeah.
Potentially, yes.
We do have some questions in the chat, so I'm just going to very quickly have a glance. I think one was about preeclampsia. So does preeclampsia have an impact on later life and CVD risk? Now, I've seen some things that say it does because it links to that gestational diabetes, but do any of you want to comment?
I mean, absolutely. And it's not that the preeclampsia causes the cardiovascular disease. It's the susceptibility to preeclampsia that is a marker of susceptibility to long-term cardiovascular disease. So it's basically giving you an early warning sign you've got dysfunctional physiology that is going to increase your risk over time. And I mean, whilst it in itself obviously has acute risks associated with it, it's that marker role that it's got that is so important, and an opportunity for us to really remind women about the fact that we need to look after their hearts.
Yeah. So touching on what Alta was saying there, that we know that there actually isn't a sex different effect of the drugs, and that drugs are effective at lowering your blood pressure. And as Gemma was saying earlier, if you can lower it, there's almost no lower threshold that's going to be adverse. Judy, I wonder if you could comment on what are the non-pharmacological ways that we can intervene. You know, we're talking a lot about this behavioral side, and if you want to start first with the clinician perspective or the individual level, like what kind of things can people do to proactively manage their risk if they know they're at high risk?
Yeah, I mean, I don't necessarily think it's any different to what most people would already know. That's already been touched on. Things like, you know, not smoking cigarettes, trying to be very conscious about the fruit and vegetables in your diet, and saturated fat and salts, you know, reducing consumption of those things, as well as going regularly to the GP, which, you know, and being proactive to get things like blood pressure and cholesterol levels measured, take tablets if you prescribe them. We know that, you know, people with cardiovascular disease can go to the GP and get what's called a chronic disease management plan. So a chronic disease management plan by the GP triggers like an annual review of your health and your cardiovascular health, but also can lead to referrals to a psychologist or an exercise physiologist or physiotherapist or dietitian, depending. That sort of triggers that conversation. So I would encourage people with cardiovascular disease to have that quite proactive conversation with their GP about a chronic disease management plan. Our research shows that only about 40% of people women with heart disease have one of those chronic disease management plans. So that would be a very sort of simple things people could do, but talk to your GP in a proactive way. If people have had heart disease or have cardiovascular disease, they can participate in programs like cardiac rehabilitation programs that are around. And we know that women, unfortunately, are less likely to be referred to such programs. So, you know, to kind of summarize where we're at here, women actually are less likely to have their cardiovascular disease risk assessed by a GP. They're less likely to have the interventions while they're in hospital. They're less likely to be prescribed the medicines. And they're less likely to get the referrals compared to men. And that is all documented in scientific evidence at the moment. So we do have a big problem. Anyway, participating in cardiac rehabilitation. And then there's a whole variety of other strategies that are available. I know Heart Foundation at the moment are offering their service for free, the My Heart, My Life program. You can ring up, it's on the Heart Foundation website, and have conversations with people, receive support via a number of mechanisms. So I think the Heart Foundation website has some good information, and you know, there are sort of apps and other things. I think it's probably good to talk to your doctor or your GP or your cardiologist or other health professional about which might be good. But there are kind of some suggestions, but I think definitely that regular checking in with the GP is a very good thing to do.
Yeah, I suppose having it on your radar. So you talk about there, even people with cardiovascular disease don't receive the same kind of proactive management, particularly women compared to their male counterparts. So do you mean that someone who's had an event, like would we say that someone who has like a high heart health check score or lots of individual risk factors that are elevated, they're at risk but don't have disease? Is that the appropriate delineation there?
Yeah, so the people with the sort of high risk factors but haven't actually had a heart attack, for example, are at higher risk and at high risk of cardiovascular disease, but haven't actually necessarily got the condition, although they may have heart disease without traditional risk factors, as Gemma would speak to. So yes, that's sort of, but it's very important that we tackle prevention in those people at high risk, and prevention in everyone for that matter, as well as prevention in people that have survived an initial heart attack or hospitalization for something. And I mean, there are other types of heart disease, things like atrial fibrillation is really important now. So that's when the atria of the heart don't beat in the appropriate way, and the heart might be racing or something, and that can put a person at high risk of things like having a stroke. So, you know, being able to have these conversations with the GP and the cardiologist and other people is important as well across these other types of heart diseases, if you like. But I'll let Gemma or someone else speak more.
Yeah, I mean, I guess we basically have been focusing on what we've understood about heart disease for quite a long time. But I think we've made moderately good progress, but it is still the biggest killer in the world, and a lot of it is not completely understood at all. And I think the next decade provides us an opportunity to actually tackle that. And if we're going to make that inroads, it's not just about people taking, making better of their own life. This is not all self-induced. Cardiovascular disease is actually something that we need to better understand, and research is actually really required to improve outcomes and heart health of women and men. So I think the areas that we can improve on and really build from this effect, the progress we've made by tackling the risk factors that we've understood for over 50 years, is actually to think a bit more about early detection of the actual host response and the actual early disease. So if you imagine these risk factors are actually attacking the blood vessels and the heart to drive that risk of heart attack and stroke, we need to have better tests that actually reflect the early disease development, which is, been difficult until now to actually detect, but ultimately is the biology that causes the disease. So I think that that's something that we really need to make progress on, and that will help each individual really, maximise their own health. But also, we've made big inroads with existing drugs. We've touched on the fact that a lot of these were probably developed based on our understanding of traditional risk factors. But in fact, we've seen some improvements over the last couple of years of clinical trials demonstrating novel approaches to atherosclerosis and therapy, including tackling the inflammatory component that determines that individual's response. And so I think this is an area that we hopefully can make big inroads, because we're certainly not winning at all. We've made big progress, but it's still the biggest killer of our race on this earth. So I think that better use of our amazing researchers to actually tackle some of these problems right across the pipeline is something that I think is really needed. And I have to, thank very much both the federal and state governments for actually investing in research in this country and seeing the research community as part of the solution to heart health. So I think we're very, very lucky and need to demonstrate, just the benefits of that.
Yeah, so I think to touch on those kind of like novel ways that we can move beyond these like population level derived risk factors to a more like, okay, even if you have those or not, how do we make that individualized and precise for that person? What way would you see that working? So one that's probably people might be familiar with that's emerged is a coronary artery calcium score, where you have an image done and it tells you whether or not there's plaques, and people are probably familiar with those plaques being caused by high cholesterol risk factors. But another area that's been talked about a lot is precision medicine, where you might provide a sample, and then based on your genes or your genetic information, people will be able to tell what type of exposure you've had, both in your family history, but also in your life course. So where would you see some of those kind of novel therapies or diagnostic tools emerging?
I'm happy to take this one if you want, but Alta, do you want, you happy for me to answer? Yeah.
Go ahead, that's fine, that's fine.
That's, look, I think we've seen cancer do this actually really well. And I think the improvements that we've seen with precision approaches to cancer that's really based on the biology and the host response combination has been phenomenal. And melanoma, is just one amazing example of that. It's interesting, atherosclerosis, or the plaque itself, has actually got an enormous number of different phenotypes if you can actually look at it, and certainly CT provides the ability to do that. So we have two different types of non-invasive imaging using CAT scan images. One is without contrast, and it's a fairly low radiation study that is designed to basically pick up any areas of calcification in the plaque of the heart. That has some major advantages. It can be scalable. It doesn't, contrast can actually cause major allergic reactions and kidney problems, and so avoiding that is always a good thing. But it's been a challenge to actually, find its appropriate evidence base and application in the community, even though it makes a lot of biological sense. And we tend to use it a lot. It's about 90 to 95% as sensitive actually as a CT with the contrast to pick up disease in a stable person that doesn't have any symptoms. And in fact, it's really indicated in people who are intermediate risk where you're not quite sure how to, you know, whether or not they should be on aggressive statin management, what your goals should be with your LDL cholesterol or the bad cholesterol. But interestingly, it's not in, certainly not in, you know, guidelines in Australia that are actually, you know, got reimbursement, etc. So we do tend to use it. The American guidelines and the Europeans certainly find a role for calcium score. But interestingly, it's in the intermediate risk group. So people that might have moderately elevated, you know, cholesterol or blood pressure. But I still have this really, you know, as a cardiologist that actually sees between 15 and 25% of our heart attack patients who come in without any traditional risk factors meeting threshold for treatment. They're actually the big pool of people out there. How do we actually help pick up risk in those individuals? And we all know that, I mean, a lot of the time when people have sudden cardiac death, over 70% of sudden cardiac death in New South Wales in the adult population is coronary artery disease, which does not happen overnight. We need to figure out how to actually measure the coronary artery disease in an easily scalable way that can be applied to the community. Not trying to guess this with, you know, risk factors that are really important at the community level, but actually measure that thing. And the calcium score provides a way of doing it. It's just not feasible really to apply that to the low risk group. But interestingly, the low risk group could have benefit from things like the polygenic risk score that you have touched on. This is something that we've seen in retrospective studies where we've got large cohorts with information about their outcome, and we've shown that the polygenic risk score, which combines, you know, hundreds of thousands of different genetic variants in a really complex score, but it is reproducibly associated with a doubling of risk if you're in the top 20 percentile of that polygenic risk score. So the top quintile has a twofold increase in cardiovascular risk. And that's independent of all of these other risk factors. So if you apply that to the low risk group and they're actually in the high quintile, that may be kind of one way that you could actually triage people that are apparently at low risk into some kind of imaging study such as the calcium score. So, you know, we haven't figured this out. A really important part of this is actually collaborative prospective studies that are actually embedded into real world and actually testing the health and the economic benefits of actually applying these tests going forward. And I think, you know, the investment of the government in research and actually trying to embed that into health as much as possible will hopefully allow us to do that in a really efficient way and actually be global leaders on this front of how do we make a difference.
Yeah, I find that really interesting because you move away then from having to do that population level. You might be at risk and you're kind of playing an odds game there based on evidence, and you're making that more into a diagnostic tool that's like, no, we know this is your level, and it makes it much more probably powerful to do something about it then when you have that individual approach. But I'd like to go to Alta to see if there's maybe a perspective that you have on, are we adequately addressing people who are at high risk with things like accurate blood pressure measurement and using the tools we have available to their best advantage, or is there a way we could improve? And then I have some questions that I want to go to afterwards. So I am getting to them in the Q&A box.
Yes, thanks. I think there's so many interesting things we can say here, but in terms of blood pressure measurement, so when you go to your GP, a blood pressure will be taken, and often the problem is in terms of accuracy. We have several issues. It's often the devices are not validated for accuracy. We trust that those the GPs are using or are validated for accuracy, but many of the devices that we buy from pharmacies or online market, 95% of them are not validated for accuracy. So those of you who are interested, and I strongly encourage you to do your own blood pressure monitoring, you have to check that the device is validated for accuracy. So you can Google that, or you can even contact me afterwards. I'm happy to show you the way, but there are ways to check whether devices are validated, and most are not. That's the main thing. And then of course, blood pressure have trajectories over day and night. And often when you're at your doctor's office, it's high because you're stressed, anxiety, or you're late for something else, and the blood pressure is high. And that is just the blood pressure at a millisecond. It does not reflect your blood pressure an hour later or an hour ago. And therefore, we are working on getting much better ways to measure blood pressure continuously over the long term. And I think that will open up a whole new world cardiovascular risk management, when we can actually have trajectories of an individual over time for several weeks and months on end, then we will get to the real blood pressure and what patterns are predictive of whether you will have cardiovascular events. So that's, I think, one aspect that's perhaps worth mentioning here.
Yeah, definitely. So we have got some questions in the Q&A. One is related to hormone replacement therapy. So I did want to ask this earlier about women's risk, particularly for those that take the oral contraceptive pill. But then I have often thought about for transgender people who take hormone replacement therapy, do we know about whether or not they're at any increased risk of cardiovascular disease, or is there any protective effect?
I'm happy to answer this one. Maybe others can come in with more information, but what I understand is that it really, there's been lots of research about it, and it's not always so clear cut. In the end, it seems it's dependent on the dose form, and the exact content of the specific therapy on whether it will have cardiovascular consequences. It will probably also depend on the individual's health status. So it's, in terms of oral contraception, we know it has an increased risk for blood clotting. But since these younger women who use oral contraceptives are often in the low risk cardiovascular range, we often don't see the major effect that it would have. But in terms of hormonal therapy, it is a tricky one. It's sometimes beneficial, depends on the content, whether it's estrogens and progesterones, which are included in the therapy. Maybe some of the others have more insight.
Oh, just to reaffirm that it obviously depends on the content. I mean, back to the oral contraceptive pill, I think the main risk associated with that from a cardiovascular perspective is actually the clotting risk more than anything else. And so deep venous thrombosis, pulmonary embolus are probably the biggest thing. But if anyone actually happens to have early atherosclerosis, it also may increase the predisposition to thrombotic arterial disease. So that's a real risk. I think in terms of transgender, obviously, you know, there's both, you know, I guess more male hormones versus, you know, female hormones in men that are transgender. So I think the benefits do depend on the benefits and risks depend on the concoction, and actually they're often adapted according to risk, and so it might be that you want to avoid some particular components of the hormonal therapy if people are known to be at risk of cardiovascular disease or hypertension, for instance.
Okay, that's great. So we have about 15 minutes left, and there is a comment from the attendees about you've got a Stride BP list, but I'm also happy to send an email out with helpful resources after this based on the discussions. So Julie, I wonder if you could tell us a little bit about whether or not in that secondary prevention space or in the outcomes of when somebody has an event, are there differences between men and women, not just in the care they receive, but actually in the way that they respond? Like I know that intervention after a stroke of getting people mobile in a short space of time is really important, but do men respond to that better because they have more muscle mass compared to women, or are there no sex differences?
I actually don't know that we know the answers to those questions. I think further to what Gemma has said, this whole concept of kind of women and heart disease is something that really only in recent years we've even started to unpack and understand and appreciate the breadth of the problem, the breadth and the depth of the problem, I guess I should say. So I think all of those answers, I can't answer them specifically. I don't know whether the other ladies can, but I would say we need a lot more work. We need to understand these things. I know it's sort of in my own work, where we might, for example, do some digital health strategies and see if women and men engage with those and they improve. And you know, it's I think the response to things like that, they're behavioral things, but I think those things, it is very different amongst men and women in some of the work that we've done. And it can even be difficult to get the women to have the time to come and participate in some of those sort of discussions and work as well. So I think probably all of those things vary. I think the ability to to participate in those types of strategies is varied. So I think it's varied on many levels, and I think it needs much work. There may be people out there that have done more work than me and then are familiar with some of the intricacies of some of the research, but I think there's research going on. There's definitely work and focus, say from the George Institute research, for example, where there's a philosophy that, you know, all studies should have some sub-analyses of the male and female differences and look at, you know, how does different populations respond to different interventions. So as we start to see some of that research coming out, we'll be able to answer some of those questions, but the other ladies might have more information than me.
No, I think just given time, I think you've answered that perfectly. I did notice that Thomas Astle-Burt's in the audience, and one of the things that I think we need to pay more attention to is actually the environment and heart health. And I think obviously, you know, you've got extreme examples of heat and also of bushfire smoke, but also Thomas has actually just published a fantastic, interesting paper on green space and the benefits of green space on cardiovascular health. So that's kind of an area that I think as a community we should be thinking about a lot more, and certainly across the globe there must be an enormous inequity in people's environmental challenges as it drives heart health. So I think the health of our planet is actually really going to be driving the health of our hearts.
So
that's a really good way to put it, yeah.
Just to say something there, for those in the audience, and there are some health professionals or clinicians that might come to the Cardiac Society meeting, Gemma, we are having a specific session on environment, climate and cardiovascular health, and we're going to be talking about all of those things, and I agree. I think that again is another sort of not well understood area, I should say.
Yeah. I think it links also with that is that we now know that air pollution, water pollution, light pollution, and noise pollution, all of those have cardiovascular effects. And I think this really links in well with the environmental aspects and climate. I know that also at UNSW, Shaji Feng has done also the work on green space and access to healthy foods and access to unhealthy foods, the distance from your home to the closest place that sells healthy stuff and unhealthy stuff. And that's really where health inequalities come in, because some people in lower socioeconomic areas simply don't have access so much to healthy foods. And we really need to work with council to address that.
One of my postdoctoral researchers, Stephanie Partridge, is doing some fantastic work at the moment looking at these online food delivery services like Uber Eats and the like, and finding that, you know, the majority of purchases made through those services are not healthy foods, and with COVID-19 it's made these types of services much more at the forefront, much more accessible, much more marketable. And you know, it's not quite, you know, access to food as such, a healthy food, but it's, you know, a changing kind of marketing and environment and the way we access food and fast food and the like. So there's all sorts of interesting areas of research going on.
Yeah, I love the idea of targeting food development or the food industry and policy level to have like minimum standards for the compilation of a meal. But I also really like what you're touching on, that if we adapt a model of having healthier communities from a well-being perspective of access to green space, maybe access to early childhood learning. But one of my like favorite studies that I keep going back to, or findings that has been replicated time and time again, is if we give children hot lunches and breakfast, their school attendance increases, their health outcomes improve, and their long-term health outcomes also improve because they have higher levels of educational attainment. And for me, that's then you're not just intervening on an individual level, you're creating a whole population or community-based improvement. We did have a question in the Q&A that's for Alta about validated blood pressure device use in clinical practice. Would you say that they're, you know, if you go and have your blood pressure measured at the doctors, that they're using a validated device to do so?
I don't have data for Australia, but I do know that there are issues in other countries. So hopefully, I think here in Australia, it should be on standard, but I think this is just also, again, a wake-up call that we make sure of that. I know often people also go to pharmacies to get their blood pressures checked. And I think throughout all of these, whether it's with your doctor, with your pharmacy, or whether you buy your own device, to check it for accuracy is of utmost importance. And also, of course, how it is taken. You know, so when people speak while the measurement is taken and overclothing, you know, it's stuff that happens. I was at the GP recently, and it was all done incorrectly, and it just made me think, you know, this is something that we see every day. And I think when you, the population, the public, everyone should educate yourselves on how this should be done, and if it's not done correctly, you should speak up too.
Yeah, I had the same thing recently. I had to have a medical assessment and my blood pressure was measured really badly. And then they're like, oh, it's a little bit high. And I was like, it wouldn't have been if we'd measured it properly. But we had another question that's about mental health and the link with cardiovascular disease. And I wanted to talk to all three of you about how do we build the data to inform the other risk factors that we're not even seeing at the moment. So like things that are emerging about depression and anxiety, you know, how much of that are we now seeing that linked to cardiovascular disease because we have better data to work with? You know, we have higher reporting of depression and anxiety, and we also have better data systems for collecting this systematically. But with us moving towards more electronic-based systems, what kind of ways do you see us informing the different types of risk factors that might be linked to cardiovascular disease? And is there opportunity to use satellite images and see how much green space there is, or population metrics? I'm going to go, Gemma.
That's a good question. I think if I don't have to make my son's school lunches, that will help reduce my anxiety. So that's one small thing. And I see people posting those Facebook posts about those amazing school lunches, and it doesn't do anything for my mental health. I think one thing to point out is that, you know, we did some research out of Australia and New Zealand just a couple of years ago in our big snapshot ACS study. And it is recommended that everybody who is admitted to hospital with heart disease or, you know, a serious heart event is screened for depression. And the data we found out of Australia and New Zealand across over 300 hospitals, only 5% of patients were getting that screening. So at the moment, you know, being able to sort of do that routine screening and actually bringing this whole mental health conversation more to the forefront clearly is getting momentum in all of society. But it is really important, and we're not really finding out and tackling this issue very well. Of course, we don't really know, you know, the links are not perfect between mental health and depression and anxiety and heart disease and vice versa, and you know, it's a bit of a chicken and egg type of a situation. But in terms of the other things, satellite imaging and things like that, I don't really know how to answer that, except I think as a community, mental health is a major issue across all areas and all age groups and male and female genders. So I think it's just something we need to be more aware of. We need to be screening for. We need to be more open about. We need to have conversations wherever we can with, you know, wherever appropriate. But others may have more exciting ideas because I've had a few minutes to think about it. But collecting the information and trying to find out, you know, how extensive the problem is and how to deal with it is a challenge in our society generally, I think, at the moment.
I mean, I've often asked myself about, like, do we have a role for registries? So like when somebody presents for a heart attack or a stroke, that where there is high data entry. So, you know, that we do deliver fairly comprehensive clinical questionnaires or assess people's living conditions. And I wonder, Gemma, if you would be interested in this, because I remember recently I was talking to one of the cardiologists that I do research with, and someone presented with a case that would have been fatal had they not have been so close to a hospital. It's because they ate something that was so high in histamine that it caused this huge immune response. I mean, there's no way that we factor those things into the type of research that we're doing in those presentations. So when you touched on the proportion of people who are having sudden cardiac death or are low risk but present with events, you know, how important do you think it is for us to have just really good data collection on that person as a whole so we can start to identify what common links might exist?
Yeah, I mean, this is one of the most fantastic opportunities that we've got to really have strategic leadership that lets data inform us of our research and implementation priorities. And we need to be working with the leaders of our health jurisdictions, so whether it be state-based or our local health districts, or obviously at a Commonwealth level, to really have much better use of routinely collected electronic data to actually populate. You know, we're very used to seeing them now, dashboards that tell us how we're going, where are the outliers, where are the things that we need to understand better, but also where are these big gaps in our ability to actually deliver evidence-based care, or where the evidence that we've got is actually not actually serving that individual. And that's something that's actually going to take, you know, the health system's become so complex because of the advances we've made that we've actually moved away from that natural fit where academics used to just be embedded into the hospital and be able to kind of, you know, come up with solutions that were relevant to their local scene. We need to actually have a big picture vision. We need to learn from what's happened with COVID. We need to have a dashboard of how we're performing on cardiovascular outcomes and quality of care, and actually make sure that we're shifting the dial with our fantastic research and also implementation of the evidence that we have.
Great.
I think to add to that, I think having data and information like Gemma's speaking about allows us to get away from sort of cherry picking who's getting helped or who's going to the GP or the hospital or what's happening. It gives us a comprehensive picture of what's actually going on, because the most typical response one would get is, oh, of course we do that. Oh, of course we also refer all the women and all the men to cardiac rehabilitation, for example. But it's not to actually look at the data that's entered into the system. You actually say, well, hang on a minute, you know, here's the numbers, and actually that's not the case. We think we might be doing that, but in actual fact, the data is really, really important to actually give that comprehensive picture so that we don't have those subconscious biases about what we think we might be doing that we may or may not be actually doing. So I think, you know, reinforcing Gemma's point, and you know, at the moment, you know, organisations like the Heart Foundation and the government is very, you know, invested and willing to support this space and help us be more proactive and comprehensive in who and how we treat people. What hasn't come up that I just want to touch on, and perhaps is relevant, is that Indigenous women are twice as likely as non-Indigenous women to actually have and die of both cardiovascular disease and stroke. So I think that's very important to talk about and just to mention. And you know, having comprehensive data stops or minimizes potentially who is and how many people sort of slip through the cracks in terms of care and understanding things as we move forward. So just to put that in there as well, I think it's important.
Yeah, I couldn't agree more. And Alta, final word, do you have anything to add to that about how we go forward with informing what we're doing?
Thanks. I fully agree with what they have said. I think the innovation in data is the future of healthcare. And we're at that cusp now. We've really benefited from COVID in that sense, as Gemma mentioned. And I think it's not about who got the event. It's about studying that throughout the life course, from children and babies throughout school, the information there. And I think that the opposing challenge we face is access to that information, because now there's privacy on the other hand, and patients and people from the public making their data available for research is the other side of the coin. So I think once we get an interface that is safe, where we can have access to all necessary data to really respond innovatively to these questions, is the future, and that is pretty exciting.
I couldn't agree more, because that's like my bread and butter, and I love it. I want us to be able to collect data in a systematic and streamlined way, but with good governance principles, because otherwise it's just never going to get off the ground. It is just about 30 seconds to 2 p.m. So thank you very much. It's just ticked over 2 by my watch. Before we depart, I would like to acknowledge that I've had help in the background from Olivia Holloway, who's been really supportive and sending me the questions from Facebook. Thank you. And I'd also like to acknowledge that this event was done in partnership with That's What I Call Science, the radio show and podcast with a team of women experts, the Australian Cardiovascular Alliance and the International Society of Hypertension, with funding received from Inspiring Tasmania. Thank you very much to my panelists for taking the time out of your busy schedule. I've learned a lot in this conversation. I'm really excited, which is always good on a Friday. And yeah, I look forward to us all continuing this conversation across Australia.
Fantastic. Thanks very much.
Well done.
Thanks to you as well, Niamh, for the organisation.
That's okay. I'm gonna